Tell me when to start. 7 o'clock, should we start?
Yeah, let's go ahead.
All right. Well, after a little hiatus, thank you all for joining. And unfortunately, I think a great deal of interest because of what you're seeing going on in the country with COVID-19. I'm Vishnu Chandi. I'm the chair of the COVID task force. We have Dr. Mullane, Katie Mullane, who is at the University of Chicago, professor of medicine and immunocompromised host. Dr. Daniel Johnson, who is the chief of pediatric infectious diseases?
Yeah.
Chief, okay, not interim chief, regular chief.
The boss.
Regular chief.
He's the boss, okay. And Dr. Lin, emeritus professor from Rush in OBGYN and well-versed with not just masking, but also obstetrics, gynecology, and maternal fetal medicine. So thank you all for helping tonight. And I'm just gonna set the stage for the rest of the speakers tonight and go over what's gone on in the pandemic and what's happening in the United States. Next slide. So dynamic changes in the pandemic are happening, and I wanted to just go through this. Next slide. So this is a Winston Churchill quote, which I thought was quite apropos, that I stole from my mentor, Dr. Robert Weinstein, which is, when the situation was manageable, it was neglected. And now that it's thoroughly out of hand, we apply too late the remedies which then might have effected a cure. There's nothing new in the story. It falls into the confirmed unteachability of mankind, want of foresight, unwillingness to act when action would be simple and effective, lack of clear thinking, confusion of counsel until the emergency comes. These are the features which constitute the endless repetition of history. I'm not a Winston Churchill fan, but I thought this was apropos to what's going on now, because not only did we go through a pandemic and we watched 600,000 Americans die, but here we are about to repeat some of this now that we actually have something that works, which quite frankly infuriates a lot of my colleagues and other folks. So next slide. So what is driving the pandemic? It's really what drives viruses, which is change in the virus, in the viral genome, which are variants. And vaccine is what is the effective therapy for this. And policy and behavior are the other factors that are really important. Behavior is almost impossible to change, but policy we certainly can help craft. So there's significant changes in the variants, which we're going to talk about tonight, from the original Wuhan strain. And the original strain was almost immediately switched to a G614 strain, which took over the world. And as you can see, these various variant numbers, which have now been changed again to alpha, beta, gamma, delta, and epsilon, et cetera, we're going to talk about. And then what's happening in South America, the outbreak and the pandemic, which is probably the most tragic from just a population perspective, is what's happening in South America, that little continent that's south of us, that nobody's talking about, which actually has a higher mortality rate proportionally than what happened in Asia, India, or anywhere else. And then what's currently happening all around us in the United States, to our neighbor to the west, Missouri, Kansas, which are having positivity rates that are as high as they were in the worst days that we had in the pandemic. Next slide. So there's two pandemics. There's a twin pandemic going on. There's a vaccinated pandemic. You know, those of us who have been vaccinated, who are very safe actually, with a very low mortality if we get infected. Unvaccinated pandemic, which are very high risk individuals with the new Delta variant, as well as other variants that are out there. And then you have to understand that fully vaccinated individuals still may get infected, but the severe illness is very rare. And people who've taken only one dose of mRNA vaccine who have not previously been infected, the current strains only provide about a 30, maybe 40% protection. And the nice thing is, even if you are vaccinated and you carry it, your nasal levels are significantly lower, so you don't transmit it to folks. So these are important little tidbits of the pandemic that Dr. Mullane and Dr. Johnson will touch on. Next slide. So this is a cartoon that's out there, and it's basically, now that we have all the big cruise ships sailing out of Miami, you have the guy who's stuck on the deserted island. Of course, he's afraid to get on the cruise ship because he's afraid of catching COVID and dying. And this is actually, unfortunately, probably true, because you see the cruise ships who return back to port after positivity. And so next slide. So these are the daily confirmed cases as of July 13th. And this is shown in the 7-day rolling average. And you can see, if the prior pandemic was predominantly over Asia, but now you see Africa with this very dark red in South Africa, Zimbabwe, Mozambique, and in those countries. And then you see South America with Peru, Argentina, which is having a horrendous outbreak, Brazil. You're having outbreaks in Indonesia, one of the most populous countries in the world. Mongolia, which was very well vaccinated with the Chinese vaccine, again, having a recrudescence, but not the mortality rates that they were facing. Russia, which is having a very big outbreak also, simply because of vaccine hesitancy. The United States has toned it down a little bit. Canada has also toned it down a little bit. Next slide. So this slide basically shows you daily new confirmed cases per million, and you saw the unrest in Cuba. Some of that unrest is related to the lack of ability to get medication and get their basic needs met. The United Kingdom has had an increase in rates. Mongolia has had an increase in rates, and India actually has dropped down because of the massive lockdown that they had. Canada, Germany, France, and the United States are also at relatively low levels, but it varies locally. Next slide. So what's the week per week change in cases? So who's going up, who's going down? Australia, which was, you know, the model state before we had vaccines because it was closed down. Delta variant got in there, and the Delta variant is causing a significant outbreak in Cambodia. Vietnam, which was a model with only having 1 or 2 cases here and there, again having an outbreak. And you can see the decrease in cases in South America, not because there's a tremendous lack of numbers, it's because they had such tremendously high numbers that the Delta is downwards a little bit. Next slide. We have a very poor short-term memory. In January 7th, we can see we had 250,000 daily new confirmed cases, 250,000 confirmed cases a day. We're now, you can see we dropped down in June, but we're headed back up again, and this needs to change. Next slide. So this is a closer look of this from May till now, and now we're headed towards 25,000 cases per day again, daily confirmed cases. So this is something that has to be dealt with. It has to be dealt with good policy, vaccination, masking, and the things that we do know about, which is some distancing. Next slide. And the share of people who received 1 dose of COVID vaccine. This is good news in many ways, because you can see Canada has over 60% who've gotten 1 dose. The United States has been kind of flat at over 50%. We have not been able to move the needle very much after the initial enthusiasm. Israel's well over 60%. The UK, after initial problem with vaccination, is now well over 60%, but their outbreak is continuing, and we're going to talk about why. And then you can see the rest. China has jumped up, and India has also got about 20% of their population vaccinated. 22% of the Indian population means a couple 100 million people. So a large number of people, but proportionately less. Next slide. And this is a different way of representing it. Share of the vaccinated against COVID-19 as of July 12th, which is fully vaccinated against partially vaccinated, and the United Arab Emirates, Chile, and Russia is way down at only 13% fully vaccinated, and then Uruguay, United Kingdom, Israel, Bahrain, and you can go down the list there. Next slide. And then the number of patients in the hospital. You can see that we're still not at a low level of the number of patients in the hospital. This is all from our world and data. We're still well over 14,000 patients in the hospital with effective vaccine. And to me, that is something, and not to most of the physicians that are on the call today, that is something that is easily controllable if we can get the right messaging, get convincing people to get vaccinated. Next slide. And the daily new confirmed cases per million deaths. Now you're talking about deaths, okay? So you can see Namibia, Tunisia, South Africa is dropping by, but look at Russia. Russia is increasing rapidly. Costa Rica, is increasing. The United States is increasing. The UK jumped up. The rest of the countries have dropped down. Actually, India is dropping down rapidly because they had a fairly high amount of rates. But the world is feeling the brunt of Delta virus. The vast majority of the world is not vaccinated. Next slide. And then the again, different representation of daily new confirmed COVID-19 deaths per million. The US is actually higher than India per million as far as deaths. The UK, France, Germany, and Canada. There are countries higher, but just to point out that our death rate is not low. Next slide. And the Illinois testing. Illinois was doing very well. It's still doing relatively well compared to where we were, but the trend, and this is from IDPH website, is up. We're now at a rolling average about 1.5, 1.6%. And the 7-day moving average. So we're going the wrong way. And the daily testing rates have dropped down. People have kind of lost interest in COVID, but the COVID has not lost interest. Sorry, the virus has not lost interest in its hosts, which are human beings. Next slide. And then these are the definitions that I think we should all get used to using. Variants of concern. Dr. Mullane is going to talk more about this. And basically, the SARS-CoV-2 variant meets the definition of variants of interest, and through comparative assessment, basically increasing transmissibility, detrimental changes in COVID-19 epidemiology, or increase in virulence or change in clinical disease. And you can see the Delta variant as well as several other variants have met this. Decrease in effectiveness of public health and social measures, or available diagnostics, vaccine, and therapeutics. And the variants of concern do meet this. Next slide. So as of July 6th, these are the variants of concern, and they're basically called alpha, beta, gamma, and delta, because we don't want to name it after the countries. I don't think we need to get concerned about the B117 after we memorized all this. It's now alpha, beta, gamma, and delta. So we're going to talk about this today. Next slide. And then variants of interest. This is with genetic changes that are predicted to know or known to affect virus characteristics such as transmissibility, disease severity, immune escape, and it's identified to cause significant community transmission and COVID-19 clusters. This doesn't quite meet the impact of variants of concern. So this is called variants of interest. Next slide. And these are the variants of interest: Eta, Iota, Kappa, and Lambda. This was by the WHO. You can go to their website and get this. Next slide. We can see that Delta variant is a predominant variant of interest, but you can see that in Brazil, 96% is Gamma. I don't have Peru up here, and Lambda has taken over Peru. Next slide. And you can see what our nucleic acid positivity is and where the outbreaks are, which is Nevada, Utah. You can see that Arkansas and Missouri are all high risk states, Texas, Florida, and you can see by the dark blue and the lesser blue where the 7-day positivity rates are going up. Next slide. And this is where the alpha variant is. You can see the alpha variant is dying down in most of the world. Next slide. And this is the Delta variant. In the UK, it compromises now 98%. In India, 97% of the testing. And down the line, Portugal, Sweden, and you can see Spain, which is having a major outbreak, now has 60%. Next slide. And the Delta variant is now found throughout the world. Next slide. And it's increasing and the Beta variant is dropping. Next slide. And Peru has a very interesting thing, because there was a question on the Lambda variant. And when you look at this, Peru has a massive outbreak with one of the highest mortalities, which probably related to not just the Lambda variant, but also healthcare in Peru. But it constitutes one of the highest mortalities. This was published recently in pre-publication. Next slide. And the Lambda variant, you can see, basically affects Peru and South America. And this is a variant of interest, which I think will become a variant of concern pretty soon. Next slide. And this is Argentina, Chile, and Peru. And you can see Peru, the green is a Lambda variant, whereas in Argentina, it's predominantly Gamma variant. And in Chile, there's a mix of Gamma variant, and now the Lambda variant is going up again. So I think this is the last slide. Next slide. And please read this article in the if you're interested in this, because it does point out to how this virus is dynamically changing and how it's going to affect how we think about what's going to happen in the next phases of this pandemic. I think Dr. Mullane is on after this. Thank you. Katie?
Hi. Since the first time I talked about variants, I was the Dora Downer. So when I look at Delta, it is now the definition of the Dora Downer. So next slide, please. As Vishnu said, currently we have variants of concern, and the Delta virus is that. When we looked at Alpha, it was 50% more transmissible than the original D614G Wuhan virus. And now when we look at the Delta virus, it's 60% more transmissible than Alpha. So it'll be 50 to 60% depending on whose data we're looking at on each slide. And I won't go through the rest of the stuff because Vishnu already did. So next slide. Again, these are the variants that are of interest. And we did have a question about Lambda, so I'll talk a little bit about that too. Next slide. And these variants that haven't really been classified yet as being important, they're ones that are designated as requiring further monitoring. But if you'll notice P3 and P2 at the bottom, and also the Theta and Zeta, and also the Epsilon California virus have gone from being variants of interest or variants of concern now to just being plain old watch out for monitoring, as other viruses have taken their place. The problem is we may run out of Greek letters because we're seeing more and more different viruses. And so we may have to change the names again, which will be very concerning because I'll get even more confused. Next slide, please. So the Delta variant originally was discovered in India in December, and it's now spread to over 100 countries. The first cases were diagnosed in the US in March. In India, there's over 31 million cases reported, but it's believed that this is a gross underestimate because of the infrastructure in the healthcare system. If we look at 31 million cases, it means that 1 in 44 residents of India have been infected, and there's been 412,000 deaths. So that means 1 in 3,300 people have died from COVID. Last week, there were 40,000 cases per day, which was a decrease from a 15% from 2 weeks ago. And the death rate has also fallen 7%. Unfortunately, when we look in India, only 5.6% of the population is fully vaccinated, and only 23% have had full doses. And when we look at, or have had 1 dose, when we look at the map of India, the highest risk areas are the tip and the top of the country. So interesting that the middle has not as much virus. So on the right and the bottom, you'll see the Delta variant on daily new cases. Certainly we had the big spike in India. And then if you look on the bottom, the UK and the US and Indonesia are all increasing. In Africa, which we don't have results on and good data on, but I'll talk a little bit about where it is there, is markedly increasing, as Vishnu said. Next slide, please. So the Delta lineage has 3 main subtypes. Delta, though, is the B1617.2. So that in itself is when we talk about Delta, the variant that we're discussing. It has multiple mutations that increase its ability to evade our immune system. So there's 5 mutations in the NTD region. There's 3 in the RBD receptor binding, and 2 of them are the scary ones, the L52R and the E44Q, which is very similar to the EEK mutation that we saw in the South African virus. And the 452 is the mutation that was seen in the California virus variants that enhanced immunity to the, or enhanced affinity to the ACE2 receptor site. There's 1 mutation that's close to the furin cleavage site, which is an important one in that it changes the structure of the receptor binding protein and makes it more difficult for antibodies to attach to the site. And then there's 1 in the S2 region. There's also now a Delta plus, like contact plus isolation. So in addition to the standard mutations, it also carries the K417N. And we don't know what the impact is going to be. This was seen in the beta viruses, which were the initial South African very aggressive virus. And so that is yet to be determined. Next slide, please. So what's different about this one? It's a faster and fitter virus. It's more transmissible, and it's probably the most transmissible to date of any of the variants that we have. So as I said, it's exponentially higher than the Wuhan virus. So if you look at the Wuhan virus, it could spread to about 2 to 3 people from one person. When we look at this Delta variant, it spreads to 5 to 8 persons who are unvaccinated, not wearing a mask. So that puts it higher than smallpox, although less than mumps or measles. It's a main concern in children and young adults, primarily because they haven't been vaccinated yet. And they're 2.5 times more likely to become infected with Delta virus. And in that way, it is a sneaky opportunist. It's hitting the people that we have not vaccinated here in our country. Next slide, please. So some of the other issues with Delta is that the viral load is much higher. So when we look at cycle thresholds in people who have the Delta variant versus older variants of the virus, the viral load is 1,000 times higher than the original Wuhan virus. So it has a higher propensity for replication in human beings. Next slide, please. So looking at worldwide, how did it spread? So in June, the Public Health England noted that it was the dominant viral sequence there. As you can see, the kind of pinky red line is the UK, and they were down very low and happy on their vaccine efficacy until suddenly Delta decided to present itself there, and it's had a exponential increase in cases. 74% of those that were sequenced and 96% that were sequenced in genotype by June 11th were Delta. And now the last time that they had the alpha virus, or the B117, was in March. So there's been no sequencing of alpha virus since March in England. June 16th, the CDC said it was a variant of concern for the United States. At that point, it accounted for 51.7% of new cases, which was up from 30.4% in March. Alpha now is about 30% of our cases. And the majority of cases that we're seeing are in those who are unvaccinated. The cases in New York City, which is now having another surge, they're up from 200 cases per day to 400 cases per day. And like Chicago, their rate of positivity has increased from 0.6 to 1.3. As Vishnu said, Indonesia is a huge problem. It's the 4th most populated country in the world. Their caseload is now surpassing India's with more than 5,500 cases per day, or 55,000 cases per day. And only 13% of their population is vaccinated. And those that are vaccinated got Sinovac, which is, will show some of the vaccine efficacies, is one that is not as efficacious. And already 20 physicians who were fully vaccinated with Sinovac have died. The caseload in India is slowly dropping. Next slide, please. So what about in the US? We had a nice lull as well. We got down to our lowest levels in June, and now we're starting to see another rise, and we hope that that will not continue as it has in England. So in the United States, we know that for all ages, at least one dose of vaccine has been administered to about 56% of the population, and about 48%, maybe a little bit more, are fully vaccinated. Usually it's in those who are older, of course, because the vaccine has only been recently allowed for children. And most of the population that has been fully vaccinated are over 65 years old. As you can see, the cases have had have doubled essentially in the period of time from 2 weeks ago till now. And hospitalizations are also up and deaths are slightly up. Next slide, please. So in the United Kingdom, which we sort of followed as far as being vaccinated, and our concern is that we're going to follow the same trajectory that they've had. In their country, 52% of people are fully vaccinated and 69% have had at least one dose of vaccine. Granted, some of those are the AstraZeneca, some of those are J&J, and not as many are the RNA vaccines. On average, they're having about 3,500 cases or 35,000 cases per day, which is an 82% increase over 2 weeks ago. And their deaths have increased 103%. Next slide. So here in the US, we sort of have the red and the blue states. The middle of the country is where the vaccination rates are the lowest and where you see the incidence of COVID being the highest. So when we look at Missouri, Arkansas, Louisiana, certain parts of Texas, certain parts of Montana and Utah and Wyoming and Colorado, those are our high risk areas. And those are all the same areas that are below average for vaccination rates. So in those areas, it's less than 50% of people are vaccinated. When we look at the coast, up to 75% of people in New Hampshire are fully vaccinated. And so the rates of increase in COVID are much lower there. We can kind of follow along as well with what was the Israeli experience as of June 6th. They found, and they used only Pfizer, that the vaccine efficacy for Delta for Pfizer vaccine was 64%, and for Alpha was 95%. But still they saw prevention of severe disease and hospitalizations. The rate though increased a little bit. It went from 97% down to 93% for hospitalizations. Next slide. But still pretty good. What are some of the worldwide consequences of this? So worldwide, only 11% of the population is fully vaccinated. In Japan right now, they're in a state of emergency in Tokyo. They had the highest number of cases per day than they did have 6 months ago. They did have a cluster with some of the athletes. So now the spectators are barred from all events. Singapore as well has had their highest number of cases in 10 months. There was a huge outbreak that was associated with a karaoke bar, the hostesses and the customers there. So now all those clubs have been shut down. As Vishnu said, Australia is no longer COVID-free and they're in the midst of a huge surge. Some other intangible things that we see is that children are missing their routine vaccinations, and very concerning that we may end up with increases in vaccine preventable diseases. As well, we've had a 30% increase in overdose deaths in the last year. And so depression and mental health issues have markedly increased. So what's going to happen with this? We kind of touched on boosters. Boosters, we know with Pfizer, if they give someone a booster shot after having the 2-dose regimen, you can see a 5 to 10-fold rise in their antibody titers. And so that may be what's coming forward. There's also some reformulation of vaccines. There's Moderna has up and coming 1273 plus 1273 against Delta that they're putting as a combination. And then they also have some different vehicles that may enhance immunogenicity that they're working on. Next slide, please. So what's different in presentation of Delta versus the other viruses? Usually presents with headache, sore throat, and a runny nose, a common cold. Less fever, less cough. Usually we do not see loss of smell and taste with it. although there is a new finding of hearing impairment in people. Next slide. So here's some of the vaccine efficacy rates. When we look at the mRNA vaccines, 88% efficacy against symptomatic disease after 2 doses. After 1 dose, it's only 33% effective. But still, we see marked reductions in hospitalizations. In Israel, as we said, with the Pfizer vaccine, 64% efficacy in preventing infection and symptomatic illness, and 93% in serious illness and hospitalization. That AstraZeneca that's at the end of the line there is supposed to be the next line. So AstraZeneca, 60% against symptomatic disease after 2 doses, 33% after 1 dose, 93% against hospitalization after 2 doses, and 71% after 1 dose. J&J, and this is United Kingdom data, 79% against symptomatic disease after 2 doses. And we're in the midst of the Ensemble 2 viral vaccine study here, 35% after 1 dose, and hospitalizations, 96% against hospitalizations if they've had 2 doses, 80% with 1 dose. And J&J is going to put more data from the Ensemble study, Ensemble 2, that has been submitted, but last I looked, it still hasn't been published yet or up on the website. Next slide, please. Again, kind of another one to tell us 2 doses are important. Qatar as well has a very high vaccine rate. After 1 dose, as you can see, the efficacy is much less, anywhere from 16.9 to 54%, depending on if you're looking at severity of disease or presence of infection or hospitalization. So getting 2 doses of an mRNA vaccine is imperative. Next slide. What about some of the therapeutic monoclonal antibodies that we have? Well, Bam doesn't do so good against the Delta virus. So bamlanivimab has very poor activity. Etosidomab, which is now the combination product with it, has good activity, and as well the product from Regeneron has good activity against it. So so there's some good benefit with those antibodies. Next slide. What about people who've had the vaccine and who've had the disease? So in Strasbourg, they have a cohort of 308 healthcare workers who had SARS, and they follow those patients, and then they look at their serum from time to time against the various viruses. So these would be people that were about 100 to 200 days after having their infection. And as you can see, those who just had COVID don't have very good activity against Delta, and that's the A chart there. And sorry, here is those patients who just had COVID infection. When they take their serum and they mix it with virus and look for efficacy, it's not very good. But certainly when they get a vaccine, we see a nice boost. This is Pfizer's vaccine, looking at a single dose, not so good. 2 doses, much better. Same with AstraZeneca. After a single dose, not so good. 2 doses, much better. Next slide. So this is the hybrid vigor that Vishnu was talking about. So looking at natural immunity from having your own infection can be enhanced by giving vaccine, and certainly having disease and vaccination markedly increases your immune responses. Next slide. So looking at vaccination and boosting efficacy, looking at neutralizing antibodies for SARS in people who just had infection alone, not so good. In those patients who had infection plus vaccine, very good. In those people who were uninfected, essentially no activity at baseline, and fair activity after their doses of 2 doses of vaccine. Next slide. And this is showing the same thing as far as T cell response. So in those people who have had SARS-2 infection without vaccine, not so much activity as far as immune response and stimulation of B cells to make antibodies. And same here, looking at the receptor binding antibody titers that are produced in those who've had SARS infection with and without receiving a vaccine. So much higher responses in those people who have had vaccine versus those not. Next slide. So this is the whole idea of what's the concern with getting another dose of vaccine and looking at enhancing our titers. So if we look at our mRNA vaccines, where we had about 95% vaccine efficacy, following those people out to 250 days, we see it falls to about 80%. But if you have a vaccine that's only 60 to 70% effective up front, when you go out to 250 days, your vaccine efficacy falls to less than 50%. And certainly the time to revaccinate people or to try to boost them would be if our titers fall below 50%. And then the same is true for responses to our variants. The further out we are from our vaccine and the lower the titers, the less likely we are to be able to bind our antibodies to bind to the virus. Next slide. So this is actually supposed to be down below with the lambda, but this is excess mortality for COVID. And as Vishu said, Peru is incredible as far as excess mortality in people who have had coronavirus. And this is certainly all related to lambda in Peru and in Brazil. But looking at their death rates compared to that in the United States and England, it certainly shows that those in underserved countries have a much higher risk of death when infected with viruses than those in the United States. Next slide. So FastVax, it's more transmissible. It can evade our antibodies after infection and after vaccination. But thus far, our vaccines seem to be holding efficacy, but we may be seeing the need for boosters in the future and not quite sure when. It may cause more severe illness. There appears to be 2 times more hospitalizations than that seen with the Alpha variant. We certainly know it's much more transmissible. And outbreaks are occurring in the United States in areas of low vaccination. And in those areas, we're seeing marked increases in cases and hospitalizations. Next slide. So looking at Chile against the Alpha and the Gamma and the Lambda variants, the CoronaVac, which is the primary one that is being distributed there, has far less efficacy for COVID-19 than the Pfizer-BioNTech vaccine. And even though overall the vaccine efficacy for decreasing disease is low, we still see a benefit in hospitalizations, ICU admissions, and in deaths. Next slide. So what's this Lambda that we're hearing about? It's a variant of interest along with those other ones that we talked about, Eta, Iota, and Kappa. It was detected in Peru in August of 2020, and it's had an increase in its incidence since February. There's 7 spike protein mutations, and when we look at sequencing in Peru, about 80 to 90% of those sequence viruses were Lambda. And they're seeing about 4,000 cases per day. More than 2 million cases have occurred overall, with the highest deaths per capita, or 9.3% case fatality ratio compared to any other area. So that alone has accounted for loss of 0.6% of their entire population. We don't know if this is just solely virus related, is it healthcare related, but it's probably a combination of the two. It appears that it in vivo or in vitro, it more readily infects cells. It's making it more transmissible, but we don't know how much more virulent it is. The convalescent monoclonal and virus induced antibodies do neutralize this variant, and that portends that the monoclonal RNA or the messenger RNA vaccines will be very effective. However, there's major concerns against the Chinese Sinovac and Sinopharm vaccines there, and the publication looking at the concerns is there for you. There's a lot of immune escape with the CoronaVac, and so we see a threefold reduction in neutralization in antibodies that are produced with that vaccine for the 614 virus versus the new Lambda. It's also present in other countries. Chile, as Vishu says, now 32%, but it has been seen worldwide. It's in 29 countries, but it doesn't seem that it has outcompeted Delta at this point in time. Next slide. So in South America, how's the epidemic there? Argentina, out of control. Brazil, very high. Chile, very high. Peru, very high. And Venezuela doesn't report much, but mostly it's because of political not reporting. Next slide. And this is just kind of interesting worldwide, looking at where the viruses are and how they're spreading in population. So when we look at Asia and China, where they had been lower through the winter, their incidence is increasing. So it makes me think about our influenza vaccines, how we see the changes in influenza seasons, depending on the countries that we're in. And you can see that the amount in North America, once we had the vaccine on board, has markedly decreased. So we have a much lower incidence compared to other countries. Next slide. So I just love this when I saw it. Every disaster movie starts with the government ignoring a scientist, which is probably true. Okay, so that's just an extra slide. Sorry, dump that one. Okay, take it away, Dan.
Thank you, Kate. Dr. Johnson is going to talk about the school guidelines, which have created a great deal of interest and controversy, and he is very well versed in this. So Dan, you're on.
Thanks a lot. Next slide. Well, we're going to talk about, could you go back for a second? We could just spend a moment, in many ways, this slide summarizes some of the most important aspects of what we have to think about in relationship to school guidelines. Community transmission, which we've spent a lot of time talking about already today, vaccine coverage, and then we really need to talk about the issues around what we should be doing with testing and outbreaks. But if we had good vaccine coverage, despite all the concerns that you've heard from both Drs. Chundy and Mullane about the variants, we know that if we had good vaccine coverage, the likelihood of seeing those variants goes down because the amount of virus circulating goes down. So when talking with families about what to do related to schools, vaccination coverage could be the most important thing to focus on with them, particularly as we're able to cocoon their children, the children who can't get vaccinated right now, kids below the age of 12. But we can cocoon them, we can protect them by vaccinating those that will be around them. And that provides a huge amount of protection for those kids. Next slide. So what do we know about schools in the pandemic? Let's first start with a little bit of background. And that is that when you shut down schools, you have a negative effect on learning for most children and on their mental and emotional well-being of both parents and children. There's data around this. It has been shown over and over again that closing schools is bad for learning in the majority of kids. Certainly, there are some children who thrive under that circumstance, but most children do not. And most experts agree that the goal is to get as many kids back into school as we possibly can, because the benefits are so great. And yes, we're balancing against the risk of acquiring and spreading SARS-CoV-2, but what we've learned is that schools are not the major site where COVID spreads. Now, the availability of safe and effective vaccine, I won't further focus on. In the United States, approximately 55% of those 12 years and older are fully vaccinated, but unfortunately, it's very uneven across the population. And of course, with the data that both Kate and Vishnu shared with everybody, you can pretty much hold a map up of where COVID is rising and exactly show a map where vaccine rates are low. Now, it's still unclear where the age cut point is for reduced risk of acquisition and transmission of SARS-CoV-2. We know, based on really now significant amount of data, that 5 years old and below is about a 50% lower risk of acquisition and of transmission. And that the 5 to 10-year-olds are really where the debate is right now, because once you get pretty much above the age of 11 or 12, the data shows that they transmit similar to adults, they acquire similar to adults. Fortunately, they don't get sick similar to adults. But the good news with the younger kids is that they tend not to spread, and that if you look at schools, it's the staff that are bringing virus into the schools and predominantly responsible for spreading it around. Next slide. If you look at the contribution of schools to the COVID pandemic, it's pretty much absent. Schools are not the reason why people get COVID. Doesn't lead to increased hospitalizations. And so, it's not even clear that if the rates are really low, that you even need to be concerned about layered protection, because it's not going to contribute in any significant way to hospitalizations. And that's because schools are protected environments. People screen individuals before they walk in the building. They may screen them with a actual test, but the truth is that the data shows us that what's almost as effective is just screening for symptomology and exposure. And so schools are really a safe haven when it comes to the COVID pandemic. Next slide. Now, just to make sure that we have definitions set, the CDC has defined low, moderate, substantial, and high transmission areas. And basically, when you look at what they're telling you to do, they're really differentiating low from pretty much everything else. Next slide. And what you'll see is in Illinois right now, as a state, we're sitting pretty much around the moderate. The state uses a different set of colors, and by and large, many counties are in moderate, but unfortunately, we have counties that are in high. And those high areas certainly match where there isn't any real vaccination that's occurred. And you can see around the St. Louis area that the big problem there is that there's a lot of transit between Missouri and Illinois, and that leads to movement of virus into those areas that show significant rates of transmission in those counties. Next slide. So what are the recommendations that the CDC has put out for opening schools? Well, first and foremost is open them. Get them open, as I said with the earlier slides. That should be our highest priority. It's good for our children. It's not bad for adults. And the end result is that we will do well as a society to have our schools open. The first step to making sure that schools are the safe haven they've been throughout the pandemic is use the tool that's most effective, always. You know, you don't use a wrench to hammer a nail. Use a hammer. So use the hammer, which is promote vaccination. Get as many people vaccinated that are going to be around those kids as possible. Protect them by cocooning them. Masking. Well, in general, people do not need to mask when they're outdoors. The risk of transmission is 1,000 times lower approximately compared to indoors. So don't need to worry, except when there are crowded outdoor settings and there's significant transmission in a community. Regardless of the mask policy at school, the recommendation is to wear a mask on school buses for both the driver and the passengers. And that's because of the crowding. But you know, if you open up all the windows on the bus, that dramatically lowers any risk of transmission on the bus. For people who are not fully vaccinated, the CDC has still said consistent and correct use of masks indoors. And they did not put a proviso on this related to transmission risk in the community. And I think that's because they're worried about all of the data that Kate and Vishnu shared. And once you take off those masks, it's really hard to get people to put them back on again. And so the CDC has adopted a conservative approach with the recommendation to mask indoors, no matter what the transmission risk is in the community. For physical distancing, the data has shown over and over again, 3 feet is safe. And in fact, it may be that when community transmission drops to very low levels, that we may not even need the 3 feet because so little disease will be coming into the schools. But you really need a high vaccination rate and a low level of community transmission in order to get to that point. But if the choice is keeping kids at 3 feet, but not having kids in school, then the CDC has clearly said, don't worry about distance, just make sure people are masking. Hand washing should be encouraged. It's not only good for a small reduction in COVID transmission, but it's good for a lot of other illnesses. So we should continue to emphasize hand washing. And I really like the phrase respiratory etiquette. It just sounds so genteel. But really what it's about is stay home when you're sick and go get tested. That's so important to keeping schools and any environment safe. And then do the contact tracing in combination with isolation and quarantining for those people who are not vaccinated. Of course, cleaning doesn't hurt, and cohorting doesn't hurt, particularly in settings where it's difficult to keep physical distancing and masking. And that's, of course, among young children. But really, that applies to areas where there's moderate or high transmission. Next slide. Now, you notice I haven't talked about screening. And that's because I wanted to do it and give it its own slide. In modeling studies, there's no doubt that screening has made a difference. Weekly screening, either once or twice a week, does reduce secondary cases by a large extent in school, because again, it keeps cases from coming into the school. But screening could be problematic in areas where the amount of disease is very low. And that's because you're more bound to have false positives than you are to have true positives when you get down to very low rates out in the community. Also, for people who are vaccinated, screening them is a useless endeavor because of the efficacy of the vaccine. You'll end up definitely having a high rate of false positives, and you'll end up restricting access needlessly and also creating other testing because of the concerns related to the false positives. So the CDC has put out guidelines, next slide, around screening and testing. If you're in low transmission, which means 10 cases per 100,000 per week or lower in an area, you do not need to screen students. And you certainly are unlikely to need to screen teachers, but in the conservative way in which the CDC acts, they've suggested for the low transmission that if their teachers are not fully vaccinated, then go ahead and screen them even in low transmission. My advice would be don't do it because of the high rate of false positives. But the CDC has recommended in moderate, substantial, and high transmission areas to go ahead and do screening of students, teachers, and staff on a weekly basis or more frequently. For high-risk sports and activities, which they differentiate from low and intermediate risk sports. So high-risk sports tend to be indoor sports that are team sports, wrestling, or outdoor sports like football. And what they're recommending there is screening on a weekly basis for those kinds of organized sports if it's the high risk, but for low and intermediate risk, in the low transmission areas, you do not need to. In the moderate, substantial, or high, they recommend that you do. Next slide. Ventilation. I found it very interesting that the CDC has put out a recommendation to consider using fans in rooms. But I want to underline, as the picture shows, the air from the fan is going outside. So it's a box window fan or some other fan that will blow air out of the room in order to more rapidly clear it, simultaneously keeping windows open. They've also made a recommendation around the use of Hepa filters, even though really there's little to no data showing the impact of Hepa filters on transmission risk. But what they are arguing is that Hepa filters will capture particles, and in so doing, they will help clear a room more rapidly. So they emphasize the use of Hepa filters in high-risk settings, such as the nurse station at school or the quarantine room at school in particular. And then, as I already mentioned, they talk about the importance of opening windows on the buses so that way you get good airflow in the buses as much as possible in order to limit risk because of the amount of crowding that goes on school buses. Next slide. And then they put in, again, a very large caveat. And that caveat is that as long as you're tracking the consequences, school administrators can decide to remove some of the prevention strategies. They would recommend that you consider making the focus on distancing being the first area to reduce in mitigation strategies, but then track it and see what happens. As long as the transmission risk in that community is low, then this is certainly should be a safe activity. If things go well with that, then they recommend that you consider the possibility of removing masks, but they emphasize doing this in a controlled way. And although they don't give details on this, my advice would be that you start with the lower school. Lower schools have shown almost no transmission. And then if that's safe in a community, if that works well, then move to the next level, which would be middle school, so that you can track this closely. So again, the largest emphasis, and I fully endorse this, is getting kids back into school, doing it through a mitigation process that leads with vaccination and then moves through the kinds of steps that we've discussed, trying to ensure that schools stay that safe environment that they are. And I think that's my last slide. Let's see. In essence, I talked about this, so we can move beyond this. But really, it's what I'm talking about here is the value of high vaccination rates and low rates of transmission in areas, leading to the ability to reduce mitigation steps. Next slide. So I'll turn things over to our colleague, Dr. Ed Lin. Ed?
Thank you very much, Dan. So when I was asked and assigned to cover this portion, I realized that being a reproductive healthcare professional, Dr. Chundy knew that I was very familiar with barrier methods, but that was contraception, Vishnu. And but we'll try to extend this to mask wearing. Also, spending a lot of my career in an operating room, I guess I'm very comfortable with the notion. What I found very interesting when I went into the science behind it is that I don't think we're going to spend a lot of time perseverating over the fact that masks work. And actually they work much more effectively than you would be led to believe initially, because it seems like such a simple technology. Obviously, everyone's very aware of the N95 respirators, and it's been hammered into our heads as long as we've been in modern medicine about, in certain situations required to wear it. But we're talking about N95 masks without the vent, which are ineffective in terms of preventing transmission. But the remarkable thing is that procedural masks, the multi-layered paper mask and the cloth multi-layered masks are still very, very effective with this. And I think this is what, that we've been led to believe that was an important strategy over the last months. But things happen. And just to review very quickly, and a lot of this was already covered by other speakers, that the CDC currently is generally recommending that if you're not fully vaccinated, you should wear a mask in indoor public places. That's kind of the honor system. And in general, you don't need to wear a mask in outdoor settings unless you're in areas where high numbers of COVID-19 cases, you consider wearing a mask in crowded outdoor settings and for activities with close contact with others who are not fully vaccinated. Now, this talks about the fact that being vaccinated, which is really the cornerstone of what we were speaking about. And I have to say that watching the behavior of people in public today, I don't think people are necessarily discriminating or even living on the honor system that was requested about, from the public. I can tell you, going to a major league ballpark, which I've done, they seem to have cornered the market on those individuals in the typical demographic with low vaccination rates, the younger adult population. And none of the people wearing masks in any area of the stadium, including the crowded, congested, concourses as we're coming in and leaving the park. But if you are fully vaccinated and you have a condition or taking medications that potentially weaken your immune system, you may need to keep taking steps to protect yourself, like wearing a mask. And of course, the CDC then says, talk to your healthcare providers. So we really want you to, because I'm talking to healthcare providers tonight, to take the initiative to try to help demystify some of the things for your patients. the idea of wearing a mask and being fully vaccinated is kind of what we call, at least in the contraceptive world, the belt and suspenders approach. I know that's kind of a male definition for people that have worn suspenders or braces, and also wear belts. It's adding another layer, if you will, of protection. Because even though we are confident that the vaccines are highly effective, I don't think anyone wants to determine whether or not they will become the minority population that gets significantly ill with a breakthrough infection, because we do know that people do suffer from these. May I have the next slide, please? So this is basically what we were talking about. The one area where you're not given a pass, if you will, by the CDC is when you're on airplanes, buses, trains, or other forms of public transportation and traveling into, within, or out of the United States in US transportation hubs. They do say that travelers are not required to wear a mask in outdoor areas of a conveyance. So if you're, an open air area on a boat or on a multi-leveled bus. Next slide, please. It's the unvaccinated people we want to emphasize wear a mask. And where the CDC has, I think, tried to be scientific, but in some ways, I think they've created a little bit of an intellectual burden, is the concept of areas with high numbers of COVID cases. Because that means that you have to know, and I'm speaking out of the public, if you are in an area with high numbers of COVID cases. All of the people speaking tonight look at data all the time, myself included, and we can tell you where there's high levels of COVID cases. And the media has tried to cover this, I think, and with regular reporting about this. But it's something which I think has kind of given a little bit of confusion to this whole discussion. And again, the CDC recommends that travelers who are not fully vaccinated continue to wear a mask and maintain physical distances when traveling. A lot of this feels like common sense, but it is a little bit confusing. Next slide, please. Now, this is another way of putting these definitions that Dr. Johnson had previously covered. And this is how the CDC has listed it, using the color coding. And this is again, the definitions, which if people are aware of this, it's almost like we should be getting blue alerts and yellow alerts and orange alerts, so people know what's life like in their community. But it's total cases per 100,000 in the past 7 days, and there's a cascade of numbers, and also the percentage of nucleic acid amplification tests, or the standard, the PCRs that are positive during the past 7 days. So that would be your positivity rate data. And this is what should be driving the decision-making. Next slide, please. So to add to the confusion, there were conflicting opinions by two respected organizations. And I know we had the same problem in my world of reproductive medicine when the WHO came out in the fall of 2019 and said, you don't have to, 2019 said you don't have to give the vaccine that's coming out to, I apologize, we're talking about 2020, that we don't have to give the vaccine to pregnant women. And then the American College of OBGYN objected, the Society for Maternal-Fetal Medicine objected, and the WHO then retracted and then said, yeah, it's still a good idea to give it to pregnant women because we're trying to prevent severe disease. So in May of this year, 2021, the CDC announced that vaccinated Americans no longer need to wear masks indoors, with some exceptions. And they did say state and local authorities can still impose their regulations. So that confused people and it concerned a lot of people. And I think many of us felt maybe this was a little premature because we knew about the fact that in the United States, COVID was still a significant problem in May. And it seemed like a little early to be relaxing the barrier protections, if you will, mitigation strategy. And then in June, when the Delta variant is starting to show up worldwide, the WHO reiterates the importance of wearing masks to stop community transmission, even where people were vaccinated. And to this date, the CDC has not revisited this stand. They're still trying to differentiate. And again, I think it adds even further confusion, or it allows further polarization depending, who you want to believe. Next slide, please. So this is how the WHO justified their position in June. And they said vaccines alone won't stop community transmission. And this is from Mariangela Simoa, who was the Assistant Director General for Access to Medications, Health Products. And again, people need to continue to use masks consistently, be in ventilated spaces, practice hygiene, maintain physical distance, and avoid crowding. Now, people have argued, well, the WHO was really making this recommendation worldwide because we were seeing such significant escalation in infection throughout South Asia. And then, as was pointed out, significant problems in South America. But I'd like to suggest that we had significant problems in many areas of the United States and still do. And it would be nice if we had some consistency. But we've given this freedom to choose where you want to go. Next slide, please. Unfortunately, mask usage is a partisan issue in the United States. Even though until recently, cases have been steadily declining as vaccination rates were going up. But that area seems to be plateauing slightly, and we may be reaching an impasse. Remember, President Biden set a target of immunization for 70% of adult Americans by July 4th, but the country fell short of it. And this was a modest, it was one dose. And we're now at about 67% of all eligible adults. And it's still 20% of Americans say they do not want to get vaccinated. So vaccine hesitancy also seems to follow party lines, which is frustrating, where 43% of Republicans say they will reject the vaccine compared to 5% of Democrats. And similarly, it was pointed out by Dr. Johnson, they're split on masks along party lines. And unfortunately, the states with the lowest vaccination rate also appear to have the lowest mask usage. And I'm not just saying states, communities within states, neighborhoods. One humorist that I saw on TV last week said, it appears that becoming severely ill or dying from COVID is becoming optional in the United States. You can pick what you want. They paralleled it to choosing to run with the bulls in Pamplona. And, you want to get gored, you have your option to do so. Unfortunately, for many people, we go back to the old adage, your freedom ends where my nose begins. And so many people do not want to share a respiratory virus, do not want to share exhaled pathogens. And those are the people that are most motivated to continue to wear masking in many situations. And just to remind you what we've said all along tonight, nearly all the COVID-19 cases in the US are now among unvaccinated. And the clusters are more frequent in Republican countries, with the Delta variant continuing to spread, and the risk of areas of low vaccination rates and high mass resistance is unfortunately getting much higher. May I have the next slide, please? So I just want to summarize before we open this up for a brief discussion, if we have any time left. We have self-determination that we're faced with. We do have mitigation strategies. We do have vaccine. We can combine them and make it even more difficult to acquire this infection. We need to empower people to understand and educate people about the fact that a lot of factors go into this. And one of the most important one is what is the density or community spread of the infection, which will dictate possibly which pathway one should go to. I just want to leave you with one last comment about masking. It's the cheapest thing. It's been shown to be quite effective, and it's safe. We're not seeing any complications from masking, despite the apocryphal tales on the internet. So I personally would urge a little bit more of an aggressive approach, and that's my personal opinion. Thank you.
Thank you, Ed. There were a couple of questions that were brought up. One is for, before we end, one is the mix and match strategy with the vaccination. And I want Katie to comment on this. Because in England, they were giving one dose of vaccine and then there was not availability. So there's data out there about using Chadox or the AstraZeneca followed by one of the mRNA vaccines. And it seems to show superiority. Katie, can you comment on that?
Yeah, I think that that's been shown to be true, and it's even been shown to be true in immunocompromised people who've had mRNA vaccine with no response, and then having J&J or mRNA and have a good response. So I think that at this point, if you don't have access to getting the same vaccine, it's okay to get a different vaccine for your second dose. And I think knowing that the vaccine efficacy for J&J is a bit lower, if it's possible to get a single dose of mRNA on top, I think that's a good idea. There's certainly no who's going to pay for it, how does it work? I mean, those are all questions that have to be answered, and there's certainly no guidelines to do that.
Dr. Johnson, one of the questions asked was, when will the vaccine be available to children less than 12?
We think that there's a good chance that the Pfizer will go in sometime in August for a request to approve vaccine down to at least age 5 and perhaps even younger. So that vaccine probably will become available in September, maybe the latest October. So look for it, and I think that once available, I would urge all to move forward with vaccinating children down to that age. I did see a question about concerns about myocarditis, and the good news there is that myocarditis incidence is very low. We're still awaiting data in the younger age group, but certainly down to age 12. We're talking somewhere in the range of 1 per 10,000 to 1 to 50,000 doses for children between the age of 12 and 17. If you look at the occurrence of cardiac complications from COVID, it's about 1%. So you're comparing a risk of 1 in 100 versus 1 in 10 to 50,000. That's a pretty good bet. So please encourage your patients to get vaccinated.
And on masking, it seems to be very confusing. Based on the data that's presented today, it seems to make, I think as physicians, we should be advocating for masking indoors, and outdoors, I think you're all pretty safe. I think that seems to be a clear-cut sort of easy proposition.
If vaccinated.
If vaccinated. If unvaccinated, you're out in the wolves. If you're vaccinated, I believe you still will be better off with wearing a mask, simply because there's a carrier state that occurs for short periods of time. Would anybody disagree with that, or are there any comments out there in the chat? Or that's one of the questions. Dr. Johnson, Dr. Lin, after reviewing this.
Yeah, I mean, I think we have to talk about being indoors with other people who you do not know their vaccine status. You know, if it's your personal family or, you know, that you're aware, but we're talking about our general activities in the public. And I know that, you know, I am trying to adhere to that. Now, granted, I feel a little more vulnerable because I'm a little bit more senior. I've been reminded by the healthcare and media that I'm old. But I do feel that we're talking about trying to avoid acquiring this infection. And even though we're comfortable with the notion that for the vast majority of people who become infected, this is not a lethal disease, but it's not a benign disease necessarily. You know, for those that develop other syndromes related to this infection. And I agree that, you know, we don't want to be transmitting. We don't want to be, you know, in this carrier state, because we don't know the immunologic circumstances of that person that may be near and dear to you that has been vaccinated, but may not be adequately immunized, you know, for the factors that we talked about tonight. And
Also, as physicians, we're dealing with people who are immunocompromised. So I think we have to be more careful.
Yeah, that's to me, you know, to me, it's very binary. If you're a healthcare provider in a healthcare setting, you should be vaccinated. And you know, and I know many hospitals are not relaxing the use of the issue of wearing masks when you're going, you know, through your clinical activities. You know, it's like walking into an operating room and performing a procedure. You wear a mask.
For children, the need to wear a mask outdoors appears to be probably insignificant, as long as it's not a highly crowded setting. So if you're talking about being outdoors, but sitting right on top of each other, then of course, if you have a moderate, substantial or high vaccination in that area, then wearing a mask is sensible. But if you're in the low range, even in the areas of crowding, it appears that children don't need to be made to wear a mask when outdoors. For indoors right now, I think it's prudent to continue to wear a mask, given the uncertainty about the movement of variants, as well as the rates across our state right now. But you know, we can all hope that as vaccination rates continue to slowly rise, albeit way too slowly, that maybe we'll reach a point where in particularly lower schools, there'll be no necessity to mask. We'll have to see.
Thank you, everyone, for putting in the extra time. I'm sorry it ran a little long, but there were a lot of topics to be covered. We will have a presentation hopefully within the next month, again, touching back on these topics, preparing for school. So stay safe, wear masks when indoors with people who are not vaccinated, and good night. Thank you all. Thank you for all your presentations.